Well, with that, welcome everyone. So my name is Shantice Mantilla. I'm with Baptist Health South Florida. And thank you all for joining us. Baptist Health South Florida being a healthcare organization that cares, we are committed to bringing you health and wellness while you stay at home and hopefully safe during these very difficult times. For those of you that are joining us for the first time, welcome. We will be adding information on the chat box. So this is webinar style. We can't hear or see you, but you will be able to see our amazing presenter, Dr. Thottam, while he shares a little bit of information regarding back pain. So the flow will be, he will talk through all of the topics, and then at the end, we will have it open up to question answers. So I will be taking your questions and sharing them with Dr. Thottam at the end. And again, thank you so much, Dr. Thottam, for being with us here today and taking time out of your busy schedule to share your expertise. Welcome.
Thank you. Thanks for having me in the nice introduction, Shantice. So welcome everybody. Good morning. I guess we're still in the morning now. This is just a general talk about back pain prevention, causes, and treatment. I guess just let me know if you guys have any questions, like Shantice was saying. Just a little bit about myself. I was born and raised in New York. I went to undergrad and medical school in New York, and then did residency also in New York, and then did fellowship in spine medicine at the Cleveland Clinic in Cleveland, and then got tired of the North, and then moved down here in July, August. I've been with Baptist since August of 2019, and working with a group of partners and everybody. They're all excellent and having the time of my life. I live in Coral Springs now, so I make an hour commute every day, or now I guess with no traffic, it's about 45, 50-minute commute. And the reason why is because the job here was very ideal for me. So I'm very happy with where we are now. Growing up in New York, just FYI, I'm a big Jets and Knicks fan, so I'm sorry if that upset some of you guys, but to make you guys feel better, my Knicks and my Jets suck, so that may make you feel a little bit better. Just a little bit about me. I like to kind of start with that just so you guys kind of have a feel for who I am. My whole goal is to kind of help. So I work in the spine center, so I'm an interventionalist as well. So I treat back, neck, mid-back pain. I'm also physical medicine rehab and training, so I do knee pain, shoulder pain, anything really. If there's something out of my expertise, I'm more than happy to look at you or see you and evaluate you. But if I feel like it's out of my scope of knowledge, I'll try to send you to where I think is the best place for you to be. But we also do most of the focus is on the spine. I do procedures where we do like epidurals, where we're kind of talk about or joint injections, and we'll talk about that later in this presentation. So kind of diving into the presentation, there's different types of back pain. There's neck pain, there's mid back pain, there's low back pain. There's different causes of pain. So it can be pain from the spinal cord or nerves, what a lot of people call sciatica. There could be facet-mediated pain or joint pain from the back. There could be muscular pain. There could be other causes. There's a section on prevention and then a section on treatment. There are different types of back pain, like we said. Back pain in quotes because a lot of people say back pain and it could be kind of anywhere. But we try to give you different regions. So the different regions, I'm going to put my mouse on the screen just so you guys can see. The pink over here is the cervical spine or the neck. The mid-back area or the thoracic spine is the vertebrae or the bones that have the ribs attached to them. And then the lower part or of the spine is the lumbar spine as well as the sacral spine. The lumbar spine is what people will call the low back region for the most part. And then the sacral spine is in the buttocks region. At the end, there's a fused coccyx, and that's usually the last tip of the spine. With that being said, your spinal cord, so the whole point of the spine, these bones, is to protect the spinal cord. The spinal cord kind of lives in this region right here, where those little holes are, or where the nerves come out of. And the actual cord ends around this region right here, L1, L2, and it becomes all these nerves hanging in water. So they call it the cauda equina, or the horse's tail, because that's what it kind of looks like. All right, so diving into each specific category. So neck pain comes from the upper portion of the spine under the skull. So that cervical spine or the neck region that we had that I'd shown you in the previous slide. It consists of vertebrae that has. So these are just anatomy. The anatomy of the vertebrae has the body, pedicle, lateral masses, and spinous processes. And from each so the vertebra, sorry, protects the spinal cord and cervical nerves as they exit at each level. Um, this is a picture of that. So you can see these are the bones, and within this area or within the bone, you wouldn't be able to see it really, but is the spinal cord. And that's the whole function of the spine or the vertebral bodies, these bones, is to protect the spinal cord and the nerves, which has the nerve or um, the nerve cells that give you sense or sensation, hot, cold, pain, temperature. I guess that's hot, cold, but temperature, pain, proprioception, where you are in space, vibration. It also helps with your strength. So if I wanted to lift my finger, it's a message from my brain through the spinal canal or the spinal cord, and then it goes through these nerves that go to my finger that say, "Hey, listen, lift up your finger," and tells the muscles to lift the finger. This is another picture of the cervical spine. It's a little bit more detailed. Essentially, we're cutting it, the bones and the disc in half. Um, so you'll see bones on one side. These are the bones and discs that we all talk about. And then on the other side, you'll see the spinous process, which is the back part of the vertebral structure. In between, you'll see the spinal cord right there. And then the spinal cord is in a sac of cerebral spinal fluid or fluid that protects the nerves. And you can see overall there's a decent amount of space. Even though the spinal cord is there, there's still space on either side of the spinal cord. Now, as we get older, what happens, these discs will start to bulge, we'll see arthritic changes, all that can kind of decrease the space where that nerve lives. So even if you have a herniated disc, technically, if the herniated disc is, let's say, it goes out to here, it's not really affecting your spinal cord, which is the main thing we were looking for. This picture is kind of both of these pictures, I guess, is kind of looking from the top down, where you'll see, what we look at in the MRI. If physicians kind of go over it with you, or any health practitioner can kind of go over it with you. There's two views that we look at, and one view is this, where we cut down the middle and we're seeing, hey, is there any big significant stenosis or narrowing where the spinal cord is, or is there narrowing from the top down where we can see it down the middle, or where the nerves come out on each side, and that we kind of will go into as we move along. The next type of back pain is the thoracic back pain. It can arise from the mid back, where there are 12 thoracic vertebrae attached to 12 ribs, and there's a picture on the next slide regarding that. There's a lot of musculature in that area, including muscles attached to the shoulder blade, the lumbar spine, in the low back, the thoracic spine, the ribs. There's a lot of musculature in that area. So this is the thoracic spine. You can see each level has a rib attached to it. You can see that your first rib is there, and then it goes down to your 12th rib down here. Now, as you go lower down in the rib cage, most of the time they're called floating ribs, where they're not attached to anything, but they do have muscle attachments, where sometimes muscles can be attached on the bottom part and then go down to the lumbar spine. The good part about this, the ribs, is that it kind of provides a little stability for the thoracic spine. So it's out of neck pain, mid back pain, and low back pain, thoracic, or I guess the cervical spine, the thoracic spine, and the lumbar spine. The thoracic spine is where I see the least amount of disc herniations or problems, because I think the rib cage stabilizes it pretty well. A lot of times when people have mid back pain, it can be either one referred from, or like shoulder blade pain can be referred from the neck, but sometimes when they have mid back pain, it's usually muscular, in my opinion. Low back pain. So this is the area of the 5 lumbar vertebrae. This is where the nerves that control your legs exit the spinal column, can be associated with the nerves of the spine, joints. So pain can be from nerves of the spine, the joints of the spine, muscles, and or joints near the spine, which are the hip and the SI joint. So this is a picture of the lumbar spine. You can see these are bones and discs that everybody talks about. This is the spinal cord right here, and then you'll see nerves coming out. So the best way for me to picture it and kind of how I explain it to patients is think of the spinal cord and the nerves coming out as like cars on a highway. So when I showed you the picture of the neck, I showed you how much space, extra space technically there was for the neck to live, the spinal cord to live. So I picture that as like 10 cars in a 15-lane highway. So even if you have, like we said, disc bulges or herniations, you technically can have some space. So it may bulge into those last 2 lanes that are being used. So that means you have 13 or 12 lanes for a 10 lane for 10 cars essentially. Same thing with where the nerves come out. When nerves come out, it's like one car taking up a 3-lane exit. So when you have disc herniations or arthritic changes in the spine, that may decrease that exit lane from 3 lanes to 2 lanes. But it doesn't mean that the nerve doesn't have enough space to live. It just means that you may be more susceptible to that nerve hitting the sides and causing radicular pain or sciatica. Another thing I want to point out in this picture is the disc has like a kidney bean shape. So the spinal cord lives in this area. This is a top-down view. The spinal cord lives in this area. You have a lot of my analogies. If you heard my lecture before, is food analogies or highway analogies. I don't know. Just two things that make sense to me, I guess. So that's why I use them. So the disc is kind of like a jelly donut. You have the outer layer, which is the dough, and then the jelly on the inside. So you can see where the annulus or the fibrous outside layer can tear, and you'll see extrusion of the disc or herniated um, disc material. Another part of this picture is the joint part. So this is the vertebral body, which is here, and then it communicates with the one below and the one above it via these joints called the facet joint. And then you'll see discs above and below that. So causes of back pain. If the nerves get pinched, we call it radiculopathy. It can be from a herniated disc. For that disc herniating, it could be arthritic changes. It could be there's a ligament in the back that can buckle, or a combination of these, which is what we usually see. When the spinal cord or the nerves get pinched centrally, so down the middle, where that central highway is, that's what we call spinal stenosis. So when it gets pinched from the nerve, when it comes out off the spinal or the central canal, and then or the central highway, and then it's on its way to the exit canal, the exit lane. If it gets pinched there, that's called radiculopathy. A lot of people call it sciatica. Both are interchangeable. When you talk about spinal stenosis, things that you worry about are really two things. One is if the spinal cord is so compressed that you're causing swelling within the spinal cord, that's called myelopathy. And then if you have, and you'll see that more in the cervical spine or the thoracic spine, and you'll see people will have symptoms of they'll have trouble walking, they'll have trouble holding things in their hands, they'll have trouble buttoning their buttons, zipping their zippers. They can have bowel or bladder issues, incontinence, being or pooping on themselves, or retention, or numbness or tingling on the inside of the legs, weakness of the hands or the legs are all things that can be seen with myelopathy. With neurogenic claudication, that's seen more in the low back, where it's so narrow that as patients walk, what happens is that area where the stenosis or that narrowing is in the lumbar spine gets worse, and that's where people will feel usually heaviness of their legs. They feel like their legs become lead. They can have exacerbation of pain, and it's usually after walking. Let's say I walk 100 feet, and then that's when I feel it every time. And then I sit down, I feel much better, and then I get up and I'm able to walk another 100 feet. So that sounds like symptoms of neurogenic claudication. The other thing that you can see with neurogenic claudication is that patients will say, hey, I can lean on a cart and I can walk for 500 feet with no problem. So that tells me that by bending, you're opening up that central canal and increasing the ability or decreasing the narrowing of that central canal. So a few nice pictures that I think are pretty good in the sense that they can tell you about pathology of the spine. So on the top left, you'll see normal. This is the top-down view. You'll see the disc. You'll see this is the spinal canal with space around it, and then you'll see the nerves coming out on both sides. This picture, you'll see cervical radiculopathy, where you'll see that this disc has herniated. You'll see the spinal cord. This side is normal, and then you can see how this side is pinched. Same concept. This is a little bit more about stenosis. So you can see there's different ways that the nerves can be affected. You can see arthritis over here affecting the nerve right here. You can see a herniated disc pushing on the nerve right there. You can see the ligament can either buckle or it can be thickened, causing some or increasing stenosis in this area. This is normal, and then same thing here. You'll see the ligament kind of thickening, and you'll see degenerative changes that can cause narrowing of that spinal cord and causing symptoms. So distribution, many times patients have different findings on their imaging and multiple levels of stenosis narrowing. So you can and arthritis. So how do we decide where the problem is? So you can have an MRI where the report shows herniations at every level. You can see arthritic changes at every level. So what's causing it? Is it the arthritis? Is the nerve being pinched? Is the herniated disc? So essentially it boils down to history and physical. By listening to a patient, I think is will give you half of your story, if not all of it, and then the rest will be done with the physical. Now, an MRI or pictures, sometimes patients come and saying, I need an MRI. It's not the whole picture. It's essentially a piece of the puzzle, not the whole puzzle. So an MRI can kind of verify what you saw in your history and physical, but it usually doesn't go the other way around, where an MRI should lead you to what the diagnosis is 100%. But without a doubt, an MRI can help support your history and physical, but most of your information and your diagnosis should come, majority of the time, if not all the time, should be from your history and physical. So essentially, by listening to somebody's history, you can tell where their complaints are. So when somebody says, hey, I have pain in my neck going down my whole arm to every finger, and it's the whole arm completely, that doesn't really help because it doesn't narrow it down for us. Now, if you can kind of figure out, hey, listen, I feel it in my shoulder blade and I feel it going down to my middle finger mostly, then that kind of tells, hey, maybe more of a C7. And then we kind of correlate that with your MRI. Same thing with sensation. So I told you the nerves control motor strength. They also control your sense, your feeling. So if you have numbness in your thumb, and then on your right side compared to your left side, and then your the rest of your fingers are normal on both sides, that tells me, hey, maybe more of a C6 problem or that nerve distribution. The same picture or similar picture. So other different causes other than nerve pain or facet joint pain. So facet joints, like we kind of said, like I told you before, is the communication between the two vertebrae. So most of the weight goes through the disc, but as the disc starts to degenerate, which happens with aging, a lot more pressure goes onto these joints of the back. Now, arthritis is kind of like gray hair in the spine. It happens if we all live old enough, we'll all get it. But the question is that arthritis causing your symptoms? And that's what the exam kind of leads you. Arthritis can also cause, kind of like in the knee and other joints, you'll see bony formations around arthritic joints. So that bony formation can kind of limit the area where that nerve comes out of and cause radiculopathy. So they're not usually, they don't always have to be separate things. They may be two things contributing to each other. So usually located in the low back and can radiate into your legs, but not past the knee. Cervical facets joints can go into your neck and into your shoulder, but not usually down your arms. This type of pain is worse with extension and gets better with flexion. So extension is leaning back with your hands on your hips, and then flexion is leaning forward. Other causes of back pain, like we said, are muscular. So sometimes you'll have muscle spasms and strains, which can be very difficult. They get very tight on you. You get cramping. Um, uh, Sometimes it happens on its own. You twist it the wrong way and you just kind of put a muscle out of whack. The other Sometimes it can be from nerves itself as well. So radiculopathy, what can happen is that the nerve gets pinched and your body reacts by tightening the muscles around it to protect you. So after a while, those muscles get tired too, and that can kind of contribute to the pain. Um, in this, for an exam, if I push, or any healthcare professional, if they push on that muscle and it's very tender, that may be a sign that it could be a muscle pain. Like I said, in the thoracic spine, a lot of the times there's a lot of muscles in that region, so that can cause pain. Usually common pain generators are the rhomboids in this area, deltoids, the levator scapula in this area as well, upper trapezius. All those are all kind of pain generators that are fairly common, and that can be from posture. It can be from scoliosis in some cases. It could be from like we said, just kind of straining a muscle, and then there's compensatory mechanisms that kind of throw everything out of whack. Other causes of back pain, there's shoulder pain that can mimic neck. So it's very important to differentiate between the two. Sometimes they're both going on at the same time. We call it schneck pain, so shoulder and neck pain. For the lumbar spine, a lot of times the hip can mask, can be masked by lumbar pain, and the sacroiliac joint also. They all kind of have similar complaints that they can all have pain in the same area, in the sense of the buttocks or the hip groin region, or and the very low back. Looking at this kind of model in the back, you can kind of see. So you can see, or let's see if we can correlate. The green is the lumbar spine, you can see, and then below that is the sacral spine. This is the iliac bone of the hip. So you can see here, right in between that orange and the white, is the sacroiliac joint. So it's very close. So a lot of people complain of pain right in this region, and it's very close to that low back region. As for the hip is right here, but it usually goes into the groin. So very common that they can kind of mask each other. So it's very important. The history and physical will also help kind of differentiate um, what pain is kind of coming from where. And it may be, like we said, a few things going on at once. It can be that the hip is acting up, kind of causing back pain, or contributing to back symptoms because of the compensation. Those are all possibilities, but a good history and physical can help you kind of decipher where to start with. These are just some pictures of the hip. You can see on the left, this is a normal hip. On the right, this is a cartoon picture of damaged cartilage and arthritic changes. This is an X-ray image. You can see a nice. This is the top of your leg bone, and this is the acetabulum, or the socket of the hip bone. And you can see there's a good amount of space there on this X-ray. Whereas with arthritic changes, you can see that space is gone, and it looks like it's bone on bone. This is a cartoon illustration of the SI joint. So I had the spine today, so it was easier to show you that way. But the same concept. This is your lumbar spine. This is your sacral spine. This is your hip bone, and then, or part of the hip bone, and then this is that joint in between. So this can be a pain generator. Hard to diagnose, in the sense that you need a few provocative tests to say, hey, that's sacroiliitis. MRIs don't do it justice, in the sense that you can see arthritic changes on CTs and MRIs, but is it really diagnostic of sacroiliitis? It's not, at least in my experience. So the only way to diagnose and treat it is by doing an injection. Prevention. So taking care of your back. It's a short slide, not a lot of bullets, but at the same time, there's some content in it. Try to avoid heavy lifting. Some patients do that for a living, so it's harder to ask that. But it's important to kind of remember proper mechanics. So using your legs more than your back, instead of bending at your waist and lifting something, kind of bending your legs, picking up something, stabilizing your back, and then using your legs to bring it up the rest of the way, is what I usually advise. If if it's something extremely heavy, or if it's heavier than what you're used to, maybe even asking somebody for help so you can kind of lift, unload the weight a little bit. Using correct posture, um, and that's kind of all the time. It's easier said than done, especially a lot of us, I'm sure, have been at, including myself, have been at home more than we've, I guess, we've been used to or accustomed to. So using the computer, and after using the computer for a while, watching a movie for a while, being on your phone for a while, everybody starts to slump down a little bit. We all see it, or we've all, we're probably doing it without even knowing it. So it's just to try to be aware of your posture, and when you notice you're doing it, try to correct your posture. Um, do some of the exercises that you can kind of stretch out those muscles. Those are all kind of things that, easier said than done. I understand that part of it, but it's something that may help you prolong getting symptoms, or prolong getting worsening symptoms, or prevent getting worsening symptoms. Be active. So perform stretches, home exercises. The main focus is core strengthening, usually back extension, but that can vary. If it's real bad lumbar stenosis, you don't want to be extending your back as much. Um, but I think there should be a strong emphasis on core strengthening. It's harder to do, and harder to kind of see results from, I think, but know that by strengthening your core, what you're doing essentially is strengthening the muscles around your spine. I kind of hit on it before. With the thoracic spine, you have the ribs. For the sacral spine, you have the hips to kind of protect your bones, that are giving extra support. When it comes to your neck and your low back, your spinal column is just the bones of the spinal column. Everything else is held up by muscles. So if those muscles get weak, what happens is more of the stress goes onto the lumbar spine or the cervical spine, and that can accelerate the degeneration. So the disc lose their strength. The arthritic the arthritis will advance. So those are all things to kind of keep in mind. So the things that I always recommend are, and I should add this to the slide, but neck exercises, as well as core strengthening, and back exercises. Eat healthy and lose weight. Also, less stress on the spine. The less weight you have to kind of walk around with, the less stress on the spine, and that will help with the being active part of it. Also, you know, the thing being, this is another thing, easier said than done, right? So, um, and I'm sure all the analogies of like jelly donut and stuff isn't helping with that part of it, but I think that by decreasing your weight or your BMI, you're just putting less stress on your spine and increasing the longevity of it. We're one of my mentors had told me we're only born with one spine, so the best way to kind of take care of it is by preventing anything bad from happening to it. So trying everything you can, eating healthy, losing weight, being active, home exercises on a daily basis, or even more than that, twice a day, 3 times a day if possible. It's a lot to ask, and like we said, it may not give you results right away, but in the long term, we've seen that it can help patients a lot. Other exercises, yoga, Pilates, have been shown to kind of help patients from what we've seen. And really any exercises, as long as it's not like you're not competitive. Competitive heavy lifting is tough. I mean, I'm sure it keeps you active, but at the same time, you're putting a lot of stress through your back. So that's something. But most of the time, I say exercises are pretty good. I think yoga and Pilates are a good place to start. All right, let's make sure this goes. All right, so treatment. So there's different types of treatment for different problems. So for muscular problems, if we think there's a muscular cause, stretches are a good start. You can also do trigger point injections in the office. And the whole point of that is to kind of reset the pain generator, the mechanisms of the of in the muscles, kind of create an inflammatory process to reset the pain. Physical therapy, focus on the stretching, range of motion. Also, we can prescribe muscle relaxants, which the main point of it is kind of like how it sounds, is to relax the muscles. For nerves or spinal cord problems, so that's stenosis or radiculopathy or sciatica, you could try medications like anti-inflammatories, so your NSAIDs. You could try Tylenol or acetaminophen. Oral. So if someone comes in with acute pain, severe pain, the whole the theory of it is that there may be a disc or arthritic changes that affected the nerve, and that nerve, like we said, kind of lives in a small space, but usually there's enough space for that nerve to live. Although it's small, there's enough space for that nerve to live. So with the inflammation, it increases that area where that nerve um, wants to live. So any changes in that area, if you decrease that pressure a little bit, usually the nerve doesn't mind it or it doesn't get affected by it. But because of the inflammation, you're feeling that pain. So if I bend a certain way or turn to my right side, I feel that pain going down my legs. That's telling me that that pressure is changing and causing more irritating that already inflamed nerve, so which may be causing that pain. So the whole point of oral steroids is to decrease inflammation. Steroids are an anti-inflammatory, so stronger than NSAIDs. So sometimes when people come in with pain that's severe for for a week, 2 weeks, a month, it may be worth it to try a course of oral steroids to decrease the inflammation. Another concept is that with steroids, for an epidural steroid injection, what we're injecting is steroids. So um, if we can do it orally, although there's systemic side effects, the hope is that the steroids will get to that area and decrease the inflammation from where that nerve is. With the epidural steroid injection, what we're doing is putting the steroids right where that nerve, where the problem is. So we know that most of the steroids is getting to that area. So maybe more effective in that way. But the oral steroids are, so the epidural may be more effective in the sense that we're getting all the medication in one area where we want it to be, whereas oral steroids may be less invasive. Um, Gabapentin, Lyrica, or membrane stabilizers, were used for seizure prophylaxis in the past to prevent seizures, and I'm sure to a point they're still used as that, but they're more for nerve pain now, or at least what we use it for is for, or what I use it for is for nerve pain. And then and it's effective. I mean, I think the whole point of it, in my mind, is to kind of decrease the symptoms until the body can get rid of the inflammation on its own. And then once the body gets rid of the inflammation, we can, my idea is to kind of take you off those medications. And then, like we said, when the nerve gets irritated, the muscles can also get irritated or spasm on you. So muscle relaxants I've seen can help patients um, with the nerve pain. Another treatment modality is physical therapy. Physical therapy and a home exercise program, like we kind of like what I've harped upon in the past, core strengthening, and then based on what the problem is, flexion or extension based exercises. Epidural steroid injections, I'll show you the next picture, is kind of uh, something that that we do here at the Spine Center, if indicated. The whole point of it, like I said, is to get the steroid right in that one region where we think the problem is, based on your history, physical, and MRI findings. Uh, and the whole idea is to decrease inflammation in that area. Uh, Risk of the actual procedure, or anytime a needle goes through skin, there's always a risk of infection, bleeding. Those are the main things. And then because of where we're going, there's always a risk of injuries to nerves too. But that's why we use an X-ray that tells us where we are. And most of the time, I usually keep, and most physicians, I believe, keep patients awake for the procedure. So um, the reason why is that as we get close to the nerve, the only person that can tell us, "Hey, I'm feeling that pressure down the legs," is the patient. So that's why we need you awake for the procedure, or I feel like I need you awake for the procedure. Um, Another treatment modality may be surgery. Now, if the herniated disc is pushing on that nerve completely, and medications, physical therapy, injections are not helping, or if that disc is pushing on that nerve, or you're having arthritic changes where the nerve is so compressed that you're getting weakness, severe pain where you can't function. Those are all kind of indications for surgery. Or if down the middle or the central canal is compressed so much that you're having bowel or bladder issues, or numbness or tingling on the inside of the thighs, those are surgical emergencies. So um, uh, that's where surgery would be the most prominent answer. So this is a picture of the epidural steroid injection, or pictures of it, I guess, or different parts of it. This is the on the right side, you'll see the X-ray beam. That's what we use, or the fluoroscope. That's what we use for the procedure itself. These are just a few pictures of um, uh, other injections that I've seen. Um, Essentially, there's two different ways for an epidural to be done. One is right down the middle. So you can see here, this is the bone, this is the back of the bone, this is the spinal canal. You can go right down the middle, which is called interlaminar, and put medication here, or you can go from the side and put medication where those nerves are coming out, those exit lanes. And you can see even when you put it transforaminal or from the sides, you see this. So before we put medication, we put contrast, as long as there's no contraindication. So the contrast kind of tells you, hey, where will the medication go once you put the medication in? And you can see that the contrast goes down the middle, which is where the central canal is, and it goes along the nerve. So it goes both ways. So even if you're going from the side, you can get medication down the middle as well. So the treatment options for the other problems or pathologies that we see in the spine, you can get facet joint mediated pain, which is those joints in the back of the neck or the lumbar spine, and also the thoracic spine. Treatment usually we start with conservative and then go to more uh, drastic or more aggressive measures. So you start with medications and physical therapy. You try NSAIDs or anti-inflammatories, Tylenol, lidocaine patches can also be beneficial. Um, you can get for actual procedures, you wouldn't do an epidural for this. You would do facet joint injections where you're putting a needle right into that joint that you think is arthritic, and you try to put steroids in there. You can also do medial branch blocks and radio frequency ablations, um, which I think I'll show you better on the next picture. But essentially, for the medial branch blocks and the radio frequency ablations, what you're doing is um, for the blocks, you're blocking those nerves, that the sensory nerves that sense pain from those joints. Most of it is sensory. There is some motor or some muscle innervation in the sense that it does some paraspinal muscles, but most of it is sensory nerves. So what you're doing by blocking those nerves is you're preventing those nerves from sending a signal to your brain saying, "Hey, this is painful. We're arthritic. This is the joint is painful." If those are successful, so we use anesthetic for those, so they will only last for 8 to, depending on what anesthetic you use, maybe a few hours or two, maybe up to 10 hours or so. Um, if they work and they get rid of your pain, you're able to do everything that you want to do um, with those after those injections for those 8 to 10 hours or whatever it is. Then you kind of move on to the radio frequency ablation part. So the radio frequency ablation is where you put those needles in that same area where those nerves live, and then uh, using sound waves, you denature those nerves or you burn those nerves. And with that, what you're doing is, getting rid of that communication. Now, usually those nerves start to grow back and they kind of get in touch with each other. Usually, maybe 6 months to a year, or maybe even more than that you may have relief from a radio frequency ablation. But when it starts to communicate again, I've seen patients come back and we have to repeat the procedure. Um, Shoulder, hip, sacroiliac joint pain, um, all are, like we said, kind of common masqueraders or other joint pathologies that can kind of muddy the waters, I guess. When it comes to neck, is it neck pain or shoulder pain? Is it back pain or hip or SI joint pain? Um, Treatments or medications. therapy again. You could do interventional procedures, SI joint injection. Like I said, you put a needle right into that joint uh, between the sacrum and the iliac bones or the hip bone, and you put steroids in there. So that's or anesthetic and steroids, and that's therapeutic as well as diagnostic. So it diagnoses it as well as treats it. Now, hip injections are also a possibility if patient is having, for hip, usually it's groin pain. So if you have groin pain, you can see severe arthritis, and you can do an injection right into the hip, and that can give patients relief. That also would be a steroid injection. You can do anesthetic too for diagnostic purposes, but usually you do steroid and anesthetic and an anesthetic for both. You can diagnose it in the beginning, and then it'll give you relief because of the anti-inflammatory process, anti-inflammatory uh, characteristics of the medication. Uh, Shoulder injections, ultrasound guided injections. You can do ultrasound guided injections to the shoulder. You can do it really into a lot of joints, wrists, knees, hips, SI joint. Those are all potential possibilities. This is a picture of that medial branch block and RFA, like we were talking about. This is more superficial. You can see the nerve is higher and deeper to this where the needle is supposed to be placed. Needle is supposed to be placed right around where the joint is, and it shouldn't be too deep. Um, when you actually do the radiofrequency ablation, a lot of patients or a lot of physicians, use different ways to test. They use either sensory or motor or both, and that's to kind of make sure that we're not affecting this nerve above or the nerve below it, and because those are motor and sensory nerves, so we wouldn't want to burn those nerves. Now, red flags. So this is my last slide, I think. So different reasons to go to the emergency room. If there's one thing that you should really take from this, I think is, and I tell every patient that or try to tell every patient that walks through these doors that these are the things that I would be concerned for. So I kind of want you guys to look out for too. So if you ever notice random back pain, especially with bowel or bladder incontinence, or peeing or pooping on yourself, or retaining, not, I feel like I have to go to the bathroom but nothing's coming out, that's a reason to go to the emergency room. Essentially, it could be that disc or that stenosis has become so severe that it's cutting off all the nerve innervation. Now, if you already have bowel or bladder incontinence, then that kind of muddies the waters, and that maybe more for a physician to kind of figure out, hey, is it more from the spine or is it more something else? Numbness or tingling on the inside of the thighs. So the numbness and tingling on the inside of the thighs is we call saddle anesthesia. So if you think about sitting on a horse, the saddle, whatever the saddle touches, if you have numbness or tingling on the inside of both thighs and the groin area at the same time, then that's something called saddle anesthesia, maybe from the back. Weakness of the hands or the legs, usually to a point where, hey, listen, I can't lift up my toe. I'm trying to lift up my toe. I'm thinking it, but it's not working. Or my hands, I can't grip something, or I can't stand on my toe. Excuse me, I can't stand on my toes. Then those are all reasons that to either be evaluated or go to the emergency room, especially if it's sudden. All of a sudden, I can't move my ankle. That's a reason to go to the emergency room. I mean, that could be stroke, could be a whole bunch of things, but it may also be from the back. Unable to use your hands, so that's what we call loss of dexterity, meaning that I can't button my hands. Like, it's my fingers aren't, the fine motor movement isn't there. I'm not able to grasp the buttons and coordinate putting on my pants all of a sudden, or it's been going on for the last week. That's something to be evaluated for. And then frequent falls. Kind of what we were talking about with stenosis of the neck. What happens is that you're cutting off the communication of the spinal cord. So your brain and your legs are in different they're not communicating well. So when you have myelopathy or narrowing of the spinal cord, causing swelling of the spinal canal or spinal cord, um, you may not feel your legs in space. So that can lead to frequent falls. You're just walking, and then boom, you're just on the ground, and that may be from a neck problem. or technically, I guess, a low back too. But most of the time, we see that in the neck. And I think that's it.
Okay, wonderful. Thank you so much, Dr. Thottam, for sharing that great information regarding back pain. So I do have a couple of questions.
Sure.
So in the meantime, if you have any additional questions or like further insight regarding the topic that Dr. Thottam reviewed, please submit it in the chat or in the Q&A. So let's kick this off. So I had a question from one of our attendees basically sharing that they've had mid back pain specifically, and you mentioned that many times this is associated with muscular, maybe some muscular issues. So what can they do? I know you talked a lot about in general what can be done related to muscular pain, but related to mid back pain specifically, what can they do for treatment or prevention of this type of pain?
Yeah, so it's a great question. It depends on where the pain is. So a lot of the times, especially in physical therapy, I think is a good start. They can kind of figure out exactly where that pain is coming from and kind of give you more detailed, because like we said, there's so many muscles in that region. Like the shoulder blade itself has, I believe, 17 to 24. Don't quote me on that, but somewhere along that range, muscles attached to it. So
We trust you.
yeah,
We trust that you know.
so so due to that, it may be worth it to kind of see a specialist in that sense and see if there's something specific or more fine tuned to which muscle we think is causing the problem. Now, in terms of thoracic pain, stretches, especially the shoulder blade stretches, squeezes, shoulder blade squeezes, and kind of stretching out the arms. By stretching out your arm, what you're doing is I don't know if you guys can see, but crossing your arm across and stretching that out, you can feel the muscle start to pull in the back. And stretching it out enough, you can kind of stretch out those muscles in the back. That may be a good a place to start as well. For prevention, I think it goes down to the same thing. It's keeping your posture. As the neck starts to drop down, your thoracic spine starts to get involved. Another potential cause of mid back or thoracic back pain can be from the ribs itself. Like there's muscles attached to each rib, and that also can cause pain, especially if one rib is kind of out of sorts. You can have dysfunctions that can cause pain, and that's actually another treatment modality that I want to mention is OMT is another great treatment option, especially for the muscle pain as well as any dysfunctions. The other things, like we said, kind of goes to the general muscle category of like muscle relaxants may be beneficial. But those are the main things, probably stretching, like learning focus exercises on specific muscle groups. And then and then if it is, even though the ribs are there to protect it, the muscles are there that are probably more common of a cause of pain there. You could also still have a herniated disc there, or especially if it shoots around to the front of the rib cage, that also could be contributing to symptoms. So something to be evaluated, maybe like a thoracic MRI to see, make sure there's nothing going on in the thoracic spine.
Great, thank you. And it's interesting because every time you talk about posture, I find myself sitting up taller and straighter.
Yeah,
And I'm sure other attendees on to every time you mention that, it's like catching yourself. So with that, like what is something that can be done, right, to help with posture and kind of that reminder, especially now since so many of us are probably working from home and sitting in front of our computers longer than what we normally would, and probably not sitting in the proper chairs either. I can just attest to myself sitting in my dining chair.
Yeah.
Definitely not the same as sitting in my desk chair.
Yeah, it's a great question. It's hard to give you an exact answer in the sense that you could put a reminder on your phone every hour. I've done that in the past, but after a while you get sometimes it's alarm. People call alarm fatigue in the morning. Same thing with reminders on your phone. You just look at it and then dismiss it. So it's kind of just trying to keep a mental note of, hey, listen, when you're doing it, try to remember, hey, when you're on your phone, try not to keep your head down and look, and try to look up, bring the phone up if you can. If you work on a computer, even like a standing desk or a desk that moves can kind of help you with reminding you, instead of sitting for 8 hours at a time, you can change positions. Um, People a lot of times ask about bracing. Is it the best? No, it's good for certain things, like it those you know so this is just kind of like a primary talk on back pain. There's other causes. There's like compression fractures. You can have masses. You can have more advanced pathology. But for compression fractures, braces can be beneficial. But in the long term, does braces really help you? Probably not. What happens is that those braces remind you of your posture, so you keep it at the time and you're in the brace, but the brace also supports you. So those muscles that keep up your back or your posture essentially get weaker because they're on vacation. So when you come off the brace, what happens is those muscles are weak, and then you're kind of behind from where you are or where you were.
Right. Any
So
stretches that you recommend for those of us sitting in front of the computer longer than normal?
Um, no, no specific. I mean, essentially, you want to kind of get up and move around, bend, kind of bend down and try to touch your toes, lean back, go through your ranges of motion, go side to side. Try to, if your hands are on each side, try to bring I guess when you're turning to your right side, try to bring your right hand further down your knee, and then go same thing on the other side. And then obviously with lumbar flexion, bending down, touching your toes, leaning back as much as you can to try to stretch out those muscles. For the neck is same thing, going through your ranges of motions, the rotation, turning to your left, turning to your right, chin down to your chest, looking up towards the ceiling, and then even the side bending your ear to your shoulder like you're holding your phone in between it. Same thing on the other side, and just kind of keeping that range of motion, as well as there's other exercises like chin tucks. You could probably look up online, chin tucks, shoulder blade squeezes. Those are all good for the neck. Uh, um, and then for the back, it'd be more like lower extremity exercises to try to help strengthen the back too.
Great, thank you. So we had another participant share that they do suffer from chronic migraines,
Hmm.
and have treatment for their migraines, but often when they have these extended migraines, they have neck pain,
Hmm.
as well as upper back pain.
Hmm.
Anything that you can recommend for them to do while they are experiencing that pain?
Yeah, so for migraines, there's also cervicogenic headaches too. So the migraines can cause headaches in the sense that you're probably in a lot of pain and discomfort, that you're limiting your neck motion or kind of keeping it tight to try to prevent you from moving your head more. So that may be causing some of the issues. It'll kind of go down to the same basics of stretching and doing those exercises to see if you can kind of relax those muscles. So I think for the neck pain, I think those chin tucks would help, and doing the range of motion. I know it'll be hard with the migraine going on. So as you're being treated for that, or as that calms down, it may be worth it to start doing those neck exercises before the neck pain gets worse.
Great, thank you. And then we have another question related to falls. So someone gave a hypothetical, for instance, if you fall and hurt your tailbone,
Hmm.
maybe more bruising than actual injury. What do you recommend, right? Because it's quite painful.
Yeah.
Once you have or suffer that type of trauma, what can be done?
Right. So that's a great question. So usually when patients fall on the tailbone, it's definitely worth it to be evaluated. I mean, they probably do an X-ray first, make sure there's no fracture. Landing on that tailbone is not fun. So, but most of the time, for the most part, uh, it's usually conservative management in the sense that um, so a lot of patients in the past we were using donuts, but we've seen that that's not really that helpful. There's a pillow that's actually like a U. So if you put it on, it looks like, I guess, like it's hard to kind of explain, but it looks like um, a neck
Like a neck
collar.
pillow, like
Yeah,
the
like a neck.
airplane neck
Yeah,
pillow.
exactly. Thank you. An
Yeah.
airplane neck pillow, but you put it, the opening is towards the back of the seat, so that way you're not putting pressure on that coccyx bone. So treatment for it usually is keeping pressure off of that coccyx bone and it gives it times to heal and the inflammation to kind of calm down. Then the medications like the anti-inflammatories should be beneficial. But once again, you kind of want to rule out any fracture or gross misplacement. There's also injections we can do where we're putting steroid in that region, either at that joint or right around that area to try to decrease any inflammation going on in that joint.
Great, thank you. So see a tip, an easy tip if you have one of those airplane pillows
Yeah, right.
and have an accident. Yeah.
Another tip, now that you brought it up, I always mean to put a slide in it, so it reminds me to tell people, but I always forget. For a lot of people with back pain, especially with standing up, um, uh, it may be worth, so when you're washing, a lot of people complain of when they're washing dishes, they feel pain in the back. So what I suggest sometimes is just opening up the cupboard below the sink, and then you can put, if you put one foot up at a time, it kind of offloads that pressure. And people have told me that, or patients have told me that they can kind of stand for longer with that tip. So maybe something you can kind of use going forward. Now, if you're not big plate washers, then pretend you heard that. But uh,
No excuse now about back pain
yeah,
while
I'm
washing
sorry.
dishes.
Yeah.
You debunked that.
I know.
So we have one more question from our
Sure.
audience. So someone shared, that they currently, have obesity and have had really severe neck and upper back pain, and
Mhm.
every time they try exercising, right, they're working towards that weight loss, things like that. But every time they exercise or are on their feet for too long, it exacerbates the pain. So it just makes the pain worse, right? So in that case, if someone does have obesity, what can they do, right, when they're trying to work on their journey of a healthier lifestyle or maybe weight loss, but are feeling pain when they exercise?
Yeah, that's a great question. We kind of go into a vicious cycle sometimes where pain can lead to lack of exercise, and then you're gaining weight, and then that leads to more pain, and we kind of go through a vicious cycle. So you know the best way to kind of answer that, I think, is one, other ways of losing weight, diet, um, other possible ways, anti-inflammatory stuff, and then, or diet, anti-inflammatory diets. The other thing is, being evaluated for what the neck and back pain is from. So is it muscle? Is it nerve? Is it arthritic joints? So that's all something that should be evaluated to see, hey, is there a big disc pushing on a nerve that's exacerbated when they're walking or with activity, that we can kind of help alleviate some of the symptoms so that you can get you more exercising. I mean, my main job, and here at the Spine Center, our main goal is to kind of keep patients functional or keep them moving and do what they want to do. Now, we see different age groups from 25 to 90s and hundreds. So, and you'd be surprised now. Well, I'm sure a lot of you aren't surprised that at 90 years old, 100 years old, people are active and playing golf and playing tennis. So it's definitely a possibility as technology gets better, as patients know earlier and practice preventative medicine and take care of their bodies. We can function to a high level and high intensity at those older age groups. So our goal is, hey, listen, you come into our office, we're evaluating you to you're in pain, but our goal is to kind of keep you functional to do what you want to do. My main, one of the things I love doing is playing basketball. So if something prevented me from playing basketball, I think that would affect me. Obviously, I won't be able to do something I love. It'll affect my mental health, it'll affect my physical health, and you kind of go down to a circle. So the whole goal is to try to prevent that from happening, one, and two, if it happens, to kind of get you out of that cycle so that we can get you better and do the things that you want to do. Like when patients come in, I tell them all the time, my goal is to kind of get you to do what you want to do, so that you can be happy and you know and move forward with life. So it's hard once you're already in that cycle to break out of it. But I think if there is something causing the pain, then we can kind of break that part of the cycle and then try to get you back on the right track.
Great, thank you. And thank you so much for sharing all of your wisdom and insight. And with that, if anyone would like to make an appointment with you or see you, right, to see if they're having some of these concerns or issues, how can they
Right.
reach you? How can they make an appointment with you?
So I'm a Baptist in Kendall, as well as South Miami. So the phone number here is 786-596-2225. And like I said, it's me, and I work with a bunch of a few of our colleagues. So there's a total, I believe, of five of us. So all of us are excellent. The reason why I joined this practice is because I believe we all think the same way. So I think we're all great. So um,
Wonderful, thank you. And I did put that phone number in the chat.
Okay.
And I just want to say again, thank you to everyone who's joined us. If you're interested in taking more of our sessions, we do have programming throughout the day, more great expert talks like this one, exercise classes, meditation classes. You can visit us at events.baptisthealth.net and search virtual. I did put that in the chat as well. Thank you so much again, Dr. Thottam, for sharing your time and your insight into this great topic. Any closing remarks you have before we sign off today?
No, well, I just want to say thank you for the opportunity. I really appreciate it. And to everybody that came and watched, I really appreciate it. Like we said, if you have any questions or concerns, just give us a call. Or I'm more than happy to see any of you or anybody else that you guys refer. Thank you for the time, and again, thank you, Shantis, for the opportunity.
Of course, thank you so much. Have a wonderful day, everyone.
Take care, everybody.